Good morning to you all. I've met some of you before, but not all of you. My name's Ezra Ewing. I'm an HG practitioner, and I work for a mental health charity called Suffolk Mind. And a long time ago, I used to be a tutor for the Human Givens College as well. And from time to time, I publish things in the Human Givens Journal. And Joe has asked me to join you this morning to give a presentation, I suppose, on some of the things that I wrote about in an article last year on REM sleep and dissociation. I'll start sharing my slides and then say a little bit about the format, so I don't want to end up repeating myself. So what Joe and Gareth, and I think maybe a couple of other people have joined meetings at Suffolk Mind that we have once a month. They haven't been with us once a month, but a couple of times I think you've joined, where I'll meet with colleagues and we'll talk about a particular issue or idea. It could be something related to the training that we deliver. It could be something that I'm working on for the Human Givens Journal. And so they've seen a lot of what I'm going to speak about before, and I hope that some of you perhaps have had the chance to read about it in the journal, in the article, Taking Leave of Your Senses. I've also been asked to give a similar presentation at the PTSD resolution conference. So kind of apologies to those of you who might be expecting to see that in a little while in October, but I also hope that having the opportunity to see it a couple of times may enable you to absorb the ideas and perhaps come up with different questions or have the opportunity to ask questions. The other thing to say about the format is that you're all supervisors, so I'm going to assume that you've got some kind of questions and ideas that you might discuss and ask of one another, and I'll chip in where I'm able to, but I don't have your experience as a supervisor of people working with counsellors and therapists, so I'll sort of defer to your expertise and you can make of the content what you will. Some of the rationale for thinking about trauma, I'm sure you'll be familiar with lots of these issues. It's an abstraction that gets used in different ways by different people. Clinicians and researchers like to have very precise definitions of what they mean by trauma, but even that's not particularly well agreed upon by psychiatrists and people working in research settings. And that's illustrated by a study which shows that following the attacks in Norway, where young people were assessed for whether or not they had the criteria for post-traumatic stress disorder, if depending on which of the psychiatric manuals you used, whether it was the Diagnostic Statistician's Manual or the International Classification of Diseases, the researchers found different results. So even amongst people looking for very precise definitions, things are not completely clear. If you are anything like me and your social media platforms know that you work in mental health, and the algorithms will bombard you with adverts for this, that, and the third. And another place to look for ideas about trauma might be attachment theory, but even that amongst researchers has been subjected to criticism over the last 10 years. And some of the more black and white approaches to talking about attachment theory, as Gareth has no doubt spoken to you about, don't necessarily hold up. Another focus of attention when people are talking about trauma are adverse childhood experiences, and there are a list of about 9 or 10 of them, and where the cumulative effect of being exposed to a number of adult adverse childhood experiences seems more likely to make people more vulnerable to trauma at later stages in life. However, what's often left out of the conversation, which I think is really important, and speaking to colleagues in the Ipswich and Suffolk area who work with survivors of sexual abuse, they emphasize the importance of positive childhood experiences. And so it's not as straightforward as, if you've had experience 1, 2, and 3, you're going to end up with the symptoms of trauma or struggle with relationships later on in adult life. We also have the influence of trauma celebrities to contend with. I don't have a softer way of describing them. I've sort of, my usual kind of private term for them is trauma gurus, but that's really harsh and people don't like that. So I've gone for celebrities. But the conversation seems dominated by personalities rather than any kind of genuine, or it seems to me anyway, it's sort of unbalanced. The emphasis is more on personalities rather than ideas and a kind of a genuine curiosity about the mechanisms underlying trauma. And you'll all be familiar with best-selling books that perpetuate some kind of older ideas about trauma that don't really stand up to scrutiny. And then the term gets further diluted when people talk about collective trauma, which assumes that a huge number of people have been affected by events in the same way. A misunderstanding about intergenerational trauma, and which is easy to confuse with the idea that if one generation have experienced a trauma, that somehow the experience is carried over to a later generation, and that's not quite the way that DNA and RNA work, although I'm not going to kind of go into that in any detail unless anybody asks me to or challenges me over it. And then there's increased request for organizations to become more trauma informed. But if you've examined the trauma informed principles, you'll see that there are abstractions and nominalizations that really need to be unpacked on a case by case basis. And the emotional needs and resources framework that you're all super familiar with is a useful way of going about doing that. And what we're advising our colleagues at Suffolk Mind to do is that, as a bare minimum, is to use basic kind of reflective listening skills to acknowledge if somebody discloses a trauma, be honest about our capacity to support them or otherwise, and ensure them that we're going to support them to access somebody that does have the right skill set to be able to support them, rather than leave them hanging and risk re-traumatizing them, for want of a better word. Anyway, that's kind of some background context I'm sure you're all super familiar with. So a model that has received lots of attention, and I'm no doubt you'll be familiar with it, and the people that you're supervising will perhaps have investigated polyvagal theory further. You may remember that Stephen Porges was interviewed by Denise Wynn in the Human Givens Journal some time ago. And polyvagal theory claims that there are 3 pathways in the autonomic nervous system and that they emerged in a particular evolutionary order. It says that the dorsal vagus, meaning the back of the vagus nerve, is involved with dissociative states and immobilization or shutdown. And that the sympathetic nervous system is involved with mobilization, including fight or flight. That you'll know all of this. But then the front, Stephen Porges argues, evolved in mammals to facilitate social engagement and connection. And therefore, the aim in therapy based on polyvagal theory is to help people find safe ways to move out of states where they're experiencing immobilization, shutdown, or they're dissociated, feeling out of their bodies, or finding it difficult to connect with the environment, and into situations where they're socially engaging with other people to activate the ventral vagus nerve and help them out of a dissociative state. And if you read case studies by Peter Levine, he will describe what look like successful treatment interventions and explain them using this idea as the context. I think I'm going to come back to the point about successful outcomes and theory and how we shouldn't necessarily confuse the two. I think it's important to maintain some critical thinking and separate them for reasons that I'll come back to. However, a number of biologists, largely led by a biologist working in Germany, Paul Grossman, who posed questions about polyvagal theory some time ago, I think maybe 7 or 8 years ago, on ResearchGate. It's had something like 20,000 views and multiple commentators, and nobody's been able to find any evidence to support Jorge's claims about the polyvagal nerve. So, first of all, the dorsal and ventral pathways are present in both reptiles and lungfish, which is contrary to Porges's claim that the back of the vagus nerve evolved first, and then that the front evolved later on in mammals. And that's well established in evolutionary biology. So, in other words, the ventral vagus, the front part that Porges argues is involved with social engagement, actually predates mammalian social behavior. And other researchers have said, well, actually, immobilization and shutdown is most chiefly associated with a structure in the brain called the periaqueduct of Gray. Now, that's a hell of a mouthful, and even neuroscientists tend to reduce it, and I'm going to do the same. They just call it the PAG. So that's one. I don't have a kind of a neat and tidy security officer metaphor for it, I'm afraid. So for the moment, it's the PAG or the PAG, if you like. All of that being said, does it mean that techniques informed by polyvagal theory don't work? If you're using techniques yourself, which maybe you've gleaned from books written by people working from polyvagal theory, or you're supervising people who are fans of polyvagal theory, and they're saying, well, actually, I used a particular technique, and the client reported that they felt more comfortable in social situations, or whatever it is. I don't think it's necessarily the case that techniques are not going to work just because polyvagal theory has been discredited by evolutionary biologists. But if we want to improve techniques, or we're curious about future improvements, or we want to make sure that people are practicing them in a way that's informed by that they're safe and effective, then I think we need to ask questions about what the underpinning mechanisms might be, and to try and understand what they are. And it won't come as any surprise to you that if you've read anything that I've written, or if I've chewed your ears off about it before, I think one place to look for the answers is in REM sleep. But before we do that, I just want to introduce the PAG to you if it's new. So you'll all be familiar with the almond-shaped structure that we refer to as the security officer, and its relationship with the prefrontal cortex, which, while the security officer may trigger the release of strong emotional arousal, we can modify our emotional responses to a certain extent, unless there's a really strong emotional response, and the security officer will look for or interact with the memory maker, the hippocampus, to try and provide some context too, hopefully. But there's also another structure which works with the security officer. That's the PAG. They have a kind of a reciprocal relationship, if you like. And the simplest way to present this, I think, is that if the security officer spots a potential threat, then the front of the PAG will put the brakes on to allow for risk assessment. So that's our. You'll know that the term freeze can often get mixed up. That you can have a freeze to risk assess, or a freeze where somebody gets stuck in an immobilized or dissociative state, and it's the front of the PAG that's involved in that. There are other structures that have been discovered even as recently as this year. Another place in the pons, or a collection of neurons in the pons. But certainly the front of the PAG puts the brakes on the rest of whatever we're doing at that moment, any other kinds of movements to allow for risk assessment. If there's no threat, then movement can resume. But let's say the security officer spots a potential threat, and the front of the PAG puts the brakes on to allow for risk assessment, and the security officer determines that there's actually a definite threat to our need for security, then it will trigger fight or flight. So far, so good. I know that you're all familiar with all of this. But what happens if fight or flight doesn't work, and the person doesn't have any control or autonomy over the situation? It's at that point that responsibility is passed to the back of the PAG. And that's when it will trigger panic attacks, immobility, dissociation, and pain relief in the form of opioids. So what does this mean? So the back PAG, which is really the kind of the part that I want to focus on for thinking about dissociation, it takes over when we have no control over events and we cannot escape from a threat. Interestingly, it also switches off the HPA axis, hypothalamus, pituitary, and adrenal axis, which is the stress response that releases cortisol stress hormones. So we actually we're no longer experiencing stress in quite the same way when the dorsal PAG takes over. There's some relief from stress and distress. The dorsal PAG can also learn patterns in order to identify future potential risks, while the front of the PAG seems a little bit more innate. And they're really associated with different emotions. So the front PAG is associated with what appears to be an innate anxiety. And in fact, when the ventral PAG, the front PAG is active, we can't actually go off to sleep. The dorsal PAG, on the other hand, is associated with learned fear. And this is why panic attacks are initiated by the dorsal PAG. If you have clients, or if the people you're supervising have clients who've been prescribed anti-anxiety medication, panic attacks don't respond to anxiety medication. So they may alleviate, in some cases, the experience of anxiety, but they won't stop panic attacks from occurring. Oh, okay, my bullet points are now in the wrong order, so I'm just going to be dictated to by the slide. Some of you may be familiar with a defense cascade model, which some psychologists have proposed, describes these different events of, freeze, risk assess, fight or flight, run away or fight back, and then dissociate. It kind of follows that they're cascading levels of defense, but that doesn't really hold up. There are actually two distinct pathways. Some interesting experiences, if you haven't experienced dissociation yourself, or you're trying to explain it to somebody else, some experiences which involve the dorsal PAG include a loss of sway. So what I mean by that is a reduction in the amount of body movement. People become very much more kind of static, frozen in their movement. And that's the case when a predator is in physical space and somebody or an animal doesn't have any control and can't get away. But also when we experience fear of heights. Just going back to the bit about not being able to get away, is an interesting and slightly unethical study. It's a Brazilian study of people who have PTSD following being held at gunpoint. So, which, if you're working in, I think the study's done with people working in law enforcement services who've been kind of involved in robberies and hold-ups, or shootouts and what have you in Brazil. And what they did was they got the participants to stand on specialized maps that measure variations in movement, but also not just whether you're standing still with your feet, but whether your body is swaying or moving. And then they'd have somebody point a wooden gun at you from 30 feet away or something, and then move closer and do it again, and then they'd be kind of right on top of you with the gun in your face. And what they tracked with multiple repeating it with multiple participants is that people's physical sway decreases, and they become more static the closer somebody is on top of you. And then, if any of you don't particularly like heights, if you cast your mind back to the experience of being at like the top of a tower, or wherever it is, you're near a cliff, you may have had the experience of feeling the urge to get as close to the ground as you possibly can. I don't mean jumping off the tower or over the cliff. I mean sort of like moving your center of gravity down to a stable base to reduce the likelihood of being blown off the top of the cliff or over the edge of the tower. And the dorsal PAG is involved in that. It's trying to reduce movement. I can't see many of your faces, so I don't know whether I've kind of like, triggered a phobia or anxiety, or whether any of you have been able to recall the experience of what it's like, where you're like, oh God, I better get really close to minimize the likelihood. It's probably, I don't know, I don't want to kind of make assumptions. Maybe it's like a tall person's thing or something, but there you go. The other thing about this insight is it casts doubt over the Virginia opossum effect, playing dead. So when you see people describing a defense cascade, or they're describing the function of dissociation and freezing, often they'll point to the Virginia opossum, which is a mammal in North America that will kind of play dead and then jump up and run away when a predator thinks that they've successfully pinned the Virginia opossum down. I'm skeptical about that explanation. Jane Goodall, the primatologist, and her husband, who spent many years observing predators and prey in the wild, their observation is that what actually happens is that when the prey is being captured, let's say it's, I don't know, a pack of lions or hyenas stalking vulnerable wildebeest on the edge of the herd, what actually happens is that the wildebeest will fight for a period of time, and then it will give up. It's as if it's accepted its own death. And I think that I'll share reasons with you in a minute for why I think that's the case. But I think that when the dorsal PAG takes over, it might be a sense in which it's like, okay, this is the end, and we're going to freeze everything, release opioid painkillers, and we're going to go into shutdown now because we don't have any control over this particular situation. Well, I've already explained that. There you go. Except I think it's just as we should remain agnostic about it, but I think it's just as easy, just as convincing a case to argue that PAG is involved with mediating death, dissociation, and pain relief. I'll pause there just for a moment because there's already quite a lot of information. And before I come back to what I wanted to say next, and I don't know whether people just want to put their hands up, or whether Joe, you want to facilitate questions. Malcolm, I can see you've got your hand up already, so if you have a particular question, I'll do my level best to answer it.
Thanks, Ezra. That was really good. I've sort of got one question and one comment. One was just as you're tracking through the diagram, and I was just thinking, you've got freeze, fight, or flight. And I was just wondering, under your template, would freeze be part of that PAG sort of putting the brakes on response, or are we still looking at REM? Where do you put freeze in all this?
So the freeze that when we're referring to initial risk assessment, where we just stop what we're doing, that's the ventral PAG. So it's the front part. And when the ventral PAG is active, it actually inhibits REM sleep. So if you're kind of anxious and concerned about something, you'll still free. You won't go. You won't. I've sort of looked for research and evidence into the relationship between the different parts of the PAG and REM sleep. And what's clear is that when the front part is active, you can't go into REM. So I kind of think of that as that's why I think of it as two pathways. I'm really following the claims of other researchers that it's not like a kind of a linear defense cascade. It's you're either kind of active and you're focused on risk assessing, and then you're going to take fight or flight. Or if that doesn't work, then you're going to go down this other pathway where the back PAG takes over.
Thank you.
In a minute. Thank you. Did you have it? You said you had another comment as well.
Just a follow-up comment. It was just that so I'm signed up to Ian McGilchrist's kind of group. He's got there's Channel McGilchrist. You pay a membership fee. He does questions and answers. And somebody asked him a really good question during one of his sort of meetings about the how EMDR works. And he just made the point. I'm just sort of throwing it in for you to sort of explore. Don't know. But he was just what he said was that he said apparently the midbrain, and from my understanding of what the model you've put up, that's the area we're talking about with the PAG. It is that top of the brainstem.
Yeah, that's right. Yeah.
So he said he saw it as a conjunction of, first of all, a lot of trauma effects are processed by the brain in the midbrain anyway. And you also said that secondly, the part of us that really is responsible for eye tracking, I mean, leaving aside the occipital, he just said that's the midbrain too. So he saw the activity of EMDR as taking place in that kind of nexus. And I just throw that in. I don't know if that's something you're familiar with or something you want to explore.
Yeah, I do. So I kind of sort of keeping an eye on time. I kind of had a certain cutoff point, but then I had some other questions that I thought might be worthwhile for you all to explore as supervisors, which are to do with the effectiveness of treatments. What I kind of, I might be completely wrong about this, but I kind of subscribe to the idea that regardless of whether it's rewind, EMDR, EFT, the havening, if any of you have come across the havening technique, which is being researched by people working in military hospitals, that they all work with a similar mechanism with the REM sleep mechanism. So Malcolm, make sure, don't let me off the hook. Make sure we come back to that question about the brainstem in a short while. Gareth.
Sorry, the plan was to go out into breakout rooms in a little while anyway to have discussion and then come back for a tying up Q&A. So you can send us off with some questions to reflect on then if you want.
Okay, thank you. Okay, Gareth, did you have a question?
Yeah, one of the things that just struck me is when people have been trying to tease out why it is that people develop PTSD, because it's, most of the time when we experience traumatic circumstances, we don't go on to develop PTSD. And one of the things that the research has thrown out is a real big factor in that is whether or not you were able to exercise control during the traumatic experience. That seems to provide a neurological explanation for why that is then. Is that what you're seeing?
Well, it's not what I'm saying, but yes, I agree. I think, yeah, you're absolutely right that that's a massive risk factor. If you're able to kind of get free of the car wreckage, then like the brain can kind of like be like, okay, we dealt with that, that's absolutely fine. But if you're trapped and you've got to wait for a period of time, or what was one of the case studies we were dealing with recently? It was this is at Suffolk Mind. It was a paramedic who'd been called out with their team, and when they got to the place, there was somebody else there that held them at knife point for like 6 hours or something like that. So there's an instance of where not only was a person's need for security unmet, their need for control and autonomy was too, and as a result, that kind of gave rise to increase the risk of them going on to develop flashbacks or intrusive thoughts or whatever it is. So yeah, I do suspect strongly that the back of the PAG is involved in that process.
And that would fit with the kind of airplane crash studies where if you got up out of your seat yourself, you're significantly less likely to have PTSD than if somebody had to help you up.
Yeah, absolutely. I think that's right. Okay, I'll say a little bit about REM sleep and why I think that might be involved with dissociation, and then I don't know whether, Joe, we kind of follow the plan of people going into breakout rooms and I hang about for Q&A or something like that. So I want to share this with you. It was in the article journal, but as far as I know, it's the earliest account we have of dissociation on record, and it comes from the Victorian explorer, and he had a number of different roles. I think he was a preacher as well and a map maker too, and he was campaigning for the abolition of the slave trade in East Africa as well. And this is David Livingstone, who describes describes being attacked by a lion. And he writes, "I heard a shout. Starting and looking half round, I saw the lion just in the act of springing upon me. I was on a little height. He caught my shoulder as he sprang, and we both came to the ground below together. Growling horribly close to my ear, he shook me as a terrier does a rat. The shock produced a stupor similar to that which seems to be felt by a mouse after the first shake of the cat. It caused a sort of dreaminess in which there was no sense of pain nor feeling of terror, though quite conscious of all that was happening. It was like what patients partially under the influence of chloroform describe, who see all the operation but feel not the knife. The singular condition was not the result of any mental process. The shake annihilated fear and allowed no sense of horror in looking round at the beast. This peculiar state is probably produced in all animals killed by the carnivora, and if so, is a merciful provision by our benevolent creator for lessening the pain of death." I think there are a few things that are interesting about that account. And of course, keep in mind that it's one person's account and we can't generalize from this. Nonetheless, Livingstone describes the experience in language which he literally calls it a sort of dreaminess. He also describes there being no pain and no feeling of terror. Now, that's interesting because, of course, we have other accounts, including Peter Levine's description of working with a woman who had been held down for a tonsillectomy when she was 4 years old and gone on to develop a dissociative response whenever she became stressed or distressed. And I think one of the interesting differences is that with Livingstone, we have somebody who is a much later stage in their life than somebody who maybe has been restrained for a medical operation or been, survived abuse of one form or another where they had no control. Livingstone's somebody who has a huge amount of experience already and seems able to find meaning in the experience. And I think that when we're working with people who've experienced dissociation following traumatic events, at least in my experience, they're people who had no control and weren't able to turn to support from other people at later stage at the time in their life when they are affected by the events, and that's something very different from what we're hearing from Livingstone. So I think it's the same mechanism but a different response. And then this is I think you pronounce her name Ioannis Soukalis at Stockholm University, and she's proposed an evolutionary connection between immobilization and REM sleep based on the common features that they share. She describes similar patterns of brainwaves, with some originating in the memory maker or the hippocampus. The release of the neurotransmitter, I can never pronounce this properly, I say acetylcholine. I know that psychiatrists don't call it that. Acetylcholine involved in switching on REM sleep in the brainstem, forebrain, memory maker, and security officer. Reduced serotonin activity in the area of the brain associated with switching off REM sleep. So some of you will know that one of the effects of antidepressant medication is to increase serotonin activity. And when they do that, serotonin inhibits acetylcholine from switching on REM sleep. So the two different neurotransmitters work as a kind of a flip-flop switch. That's also the case in immobilization. A surge in heart rate and respiration, although she's careful to say that gradually declines during immobilization. Well, if you've sort of measured your sleep or measured your heart rate when your watch presumes to tell you that you're in REM sleep, then you'll see that it fluctuates. And also muscle tone and reflex signals between nerves decrease. So we sort of go into tonic immobilization, while minor muscle groups like eyes and face muscles and limbs jerk independently. Mobilization in both states can last for up to 20 minutes or in rare cases even longer. You'll know about sleep paralysis, which is a form of immobilization. Just as an aside, when people ask me about that, whether it's when I'm working as a counselor or a therapist or I'm delivering training, it's useful to explain to people that it's just the body trying to keep them safe so they don't act out their dreams, and then immobilization will switch off after a few minutes. Sort of reduces people's panic if they're experiencing sleep paralysis. Soukalis also writes, as you all know, that both immobilization and dreaming are responses to emotional arousal, central emotional concerns. She's not quite as succinct or precise as you all would be, so I'll skip over that. We also know that after a night where REM sleep is lost to insomnia, we're more at risk of dissociating the next day. Whereas the better our sleep, the more we're able to remain focused and the less often our attention drifts. Another aside, people tend to talk about dissociation as a kind of a trauma response or something negative, but you'll all know that actually we dissociate all of the time when we switch attention from one task to another or when we're daydreaming. It's not necessarily a bad thing. I'll pause there and just ask for any clarification questions and then come back to that just to kind of give the final kind of topics for discussion, if that's okay. That will make sense so far. Okay. Do you all know it already? Sure you do. Okay, right. So just a kind of, what would we do with this information? I think it helps us to sort of provides us with a theoretical explanation for what's going on during dissociation. While we should acknowledge that it will take many different forms for different people, we might be thinking about dissociation following, a specific traumatic event. It might be traceable to an event in childhood where somebody had little control or autonomy over what was happening to them. But it might also help to explain other experiences. So if you've had clients with non-epileptic seizures, and they may describe to you sort of noticing the onset, they'll become aware of the onset of when they're going to have a seizure, and then they'll have one. And I'm a little bit skeptical about the labeling of things as non-epileptic seizures. It seems to be dished out when they've not been able to find something wrong with a person's brain, quote unquote. Then it gets given to people. The epilepsy label gets given to people that don't appear to have any brain damage as well. So it seems to be a little bit of a lottery, and you usually have to wait a long time before you get those sort of diagnoses. But perhaps dissociation, this kind of back of the PAG, also helps to explain non-epileptic seizures if you've worked with anybody that experiences those. And also things in the article I wrote about the functional syndrome amongst women in, I think it was in somewhere in Scandinavia, I think in Sweden. They were Yazidis from a part of the Middle East who had been taken prisoner, or they were slaves of the Islamic State, and then they'd been able to escape, or they were rescued, and then they were refugees in Sweden. And doctors couldn't understand why they seemed so withdrawn and unresponsive, and they thought that initially that it was a deliberate thing, that they just weren't engaging. But those women, on further investigation, it was found that those women were still awaiting the outcome of their asylum and refugee application. So they, in a very real sense, didn't know whether they were going to be able to remain in Sweden and try and rebuild their lives, or whether they were at risk of being deported back to the hell that they'd escaped from. Just some comparisons between REM sleep and trauma treatment to think about, and how we might use this idea of the PAG to think further. So as you know, when we're dreaming, the emotions we've not acted upon during the day are live. And that's true with treatment as well. We need to make sure that the emotions connected to traumatic memories are live as well. When we fall asleep, we become dissociated from what's going on around us. And that's true when we're working with somebody, whether we're using rewind or somebody is using another technique. The person's being helped to dissociate to prevent the security officer from being alerted by what's going on around them. As the images in our dreams move, they distract the security officer, causing temporary amnesia, or at least we think that's what's happening. It might be the case that movements in things like EFT, EMDR, and the havening. I'll ask you again in a moment. Just think. I'd like to know who's heard of the havening technique. There's a protocol description in a study paper, and it's really bizarre. It even involves singing "Happy Birthday" and skipping and all sorts of things. In any case, maybe that helps to distract the security officer. I don't know. And then in dreaming, the memory maker is able to sort of complete expectations metaphorically that we've not been able to act upon when we're awake. And we can argue that mirrors the process of changing the meaning of a traumatic memory when a person is sufficiently dissociated. So could dissociative reactions develop when the first two stages of that process are interrupted? So what I'm suggesting is that somebody is exposed to a traumatic event and they're overwhelmed by it and unable to resolve it. And so they become dissociated, but the meaning of the event has not been changed for them. They're still stuck kind of halfway through that process. Could we use these ideas to kind of step back and examine what's true of all effective trauma treatments and how they compare to the process of REM sleep to improve our own practice and our own understanding of how to treat trauma effectively? It's probably about a day's worth of thinking there, I would have thought. So I'll